broad audience, but also to reconnect with people that have meant so much to me over the years. I think I'm going to go ahead and get started. If everybody's seeing my screen. And I also want to thank Melis Delacoste of Doctoloop for presenting this, for suggesting this webinar. And I think that we will have lots of opportunities to share information with the public and with our colleagues in the setting of Doctoloop. And it's a pleasure to be doing this. I just want to get started. I'm hearing some background noise there, but this is just just by way of introduction. This is just the information that if I were giving a medical talk to medical people would be kind of like my resume and my credentials for being able to talk about a topic like this. I have been on the faculty at Weill Cornell and New York Presbyterian since 1993. I've been there finishing my 40th year. And I came out about a year and a half ago into this practice to spend most of my time doing patient care and still spending a part of the week at Cornell, mainly in the operating room in the cath lab. So I really feel like I've carved out the best of both worlds for myself. But my real resume, and I think my real background for talking to this group, because we do have medical professionals and parents and school personnel and all of the people who are important to the care and safety of our young athletes, is that this is my resume as a sports parent and as a parent of two children. These are the schools that my two sons have belonged to, the places that I've coached, the camp, many years for my kids at Brant Lake Camp, and then all of the other areas where my sons have played sports. And I think that we go into any discussion like this with the understanding of how important sports are, and not just sports, but all the demanding physical activities that our children and our young people might find themselves engaged in. When we talk about sports, we're not leaving out dancing, the athletic endeavors that are not as organized as sports. But it's important to realize that sports do a lot for children, adolescents, young adults, and all of us throughout life, not just in keeping us healthy, but in keeping us and keeping them happy. And in a lot of people, their athletic endeavors are as important to their development of their personal encounter and their personal identity as anything else that they do. And so we want to be always pointing our young people onto the field, into the pool, onto the dance floor, and not away from that. But since there are risks and cardiac risks involved in all those things, we want them to do those things safely. And the most important thing, and I'll mention this several times during the course of this, when a person is found to have one of the diagnoses that might cause risk for them when they do activities that are physically involved, our job is not to take those people off of the field and off of the court. Our job is to try to find a way for them to continue to do those things safely. So I think gone are the days where a cardiac diagnosis was the end of a person's athletic participation. And I'm grateful to the fact that we have evolved in that way and continue to evolve in that way. And what a lot of this is going to be talking about is and confronting it head on is the risk of sudden cardiac death with athletics. And I know from talking to parents over 35 years, whenever anybody is pointed to us as a pediatric cardiologist, particularly for any symptoms, whether it's chest pain, whether it's fainting, whether it's palpitations, fatigue, shortness of breath, the question is that complaint, but the question in the background, the often unspoken question is, should I be worried that my child is going to be one of those people that I've read about in the paper or that I've seen on social media? And if we don't confront that risk or that fear, then we're really not telling the full picture. And the full picture is that about 2,000 times a year in this country, young athletes who were previously healthy will have a sudden cardiac arrest while they're participating. That's about 1 in 50,000 athletes per year. And the best way to survive one of those things is to have known about it beforehand and have taken precautions. Some precautions might be staying out of the activity that you were in. As you can see, the survival rate of a person who has a cardiac arrest on the field, if there's not a defibrillator present and there's not effective CPR, is less than 10%. So we want to find those opportunities to identify people beforehand, prevent those occurrences. But if they do happen, we want equipment and trained personnel on the field to overcome that. But again, the most important thing would be to find these conditions beforehand. And these things, as I said, it happens about 2,000 times a year. Over the course of the years, sometimes this happens in people that are in the public eye. And those are situations that are tragic even beyond the community that an individual lives in. And there are often opportunities for us to be able to learn more and to have better awareness of these situations. These are a few of the people that depending on how old you are, you'll remember some of these. Pete Maravich, one of the great basketball players of all time. And there's actually an interview during his playing years where he said something about having good health. And he said, I don't want to be a guy who plays in the NBA for 15 years and then drops dead in his driveway when he's 40. And that's exactly what happened to him from a congenital coronary artery abnormality that he had since birth, played a long career, but at age 40, just playing a pickup game in his driveway. Hank Gathers, a lot of people will remember because his cardiac arrest was actually televised in the West Coast Athletic Conference basketball tournament. Hank was one of the great players, would have probably been one of the top 3 picks in the NBA draft, and he died from exercise-induced ventricular tachycardia, which had been known about beforehand because he had had a collapse earlier. He was diagnosed, he was on medication, and that medication being beta blockers, he felt made his performance less effective, and he stopped taking it. So that's the other end of the bridge. When we find these things and go out of our way to make people healthy enough to play, we have to make sure that they're compliant. And then the other one that I always like to mention is Flo Hyman, who was a great volleyball player. She was the captain of the United States volleyball team that won the 1984 gold medal. And she passed away also in a televised volleyball match on ESPN from an aortic aneurysm. And if you ever see a picture of Flo Hyman nowadays, no one would look at, she had this beautiful, long, lean appearance that would be characteristic of Marfan syndrome today. Time, there was not such awareness, and anybody with that body habitus who's an athlete would usually get pointed nowadays for an echocardiogram to look at their aorta. These are some of the people who have survived cardiac arrest. Everybody remembers Damar Hamlin, who suffered a cardiac arrest from commotio cordis during an NFL game. He was struck right in the chest and collapsed on the field. And because there was immediate medical response, he not only survived that, but came back and played the next season. Bronny James is an important person to mention. We don't know officially what diagnosis he had, but Bronny, right before his freshman year at USC, had a cardiac arrest playing basketball. He survived because there was an AED there and people who knew how to use it. And he has continued to play basketball, not only at USC, but in the National Basketball Association. And when we talk about the current guidelines for athletic participation, even though we're not sure what diagnosis it is that Bronny had. Whatever it is, it's a diagnosis that, based on his event, had that happened 10 years ago or even 5 years ago, he would have been removed from competition. But nowadays, under proper supervision, people can continue to play. So what is sudden cardiac death? It's a swift loss of cardiac activity that usually happens without warning. It can happen because of a structural problem. Usually the least common pathway is arrhythmia. So the heart beat, the electrical activity of the heart becomes abnormal. And most of the causes of sudden cardiac death, this is not the same as a person my age having a heart attack from coronary artery disease. That can be sudden, but we're talking about the normal healthy person without coronary artery disease who has a cardiac arrest while they're playing sports, usually in the first 2 or 3 decades of life. There's an American registry of these events that's been carried on by a fellow named Barry Marin, whose son has now become pretty much one of the leading voices and the leading experts in sudden cardiac death. In that database, these are basically the main diagnoses. And the first one is always a thing called hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy expresses itself usually in the second decade of life. It's one of the leading diagnoses for EKG screening. It's said that 95% of patients with hypertrophic cardiomyopathy will have an abnormal EKG by the second decade. And that's one of the great targets for screening and for early identification. The other piece of the pie chart that I like to point out, though, is this one, which is the coronary artery anomalies. Curiously, in the United States database, that is the second leading diagnosis, although around the world a little bit less so, and that may have to do with even detection after the event. I mentioned coronary artery abnormalities because that is one that will not be identified on a screening EKG, but would need to have a screening echocardiogram. So person can have a normal screening electrocardiogram, be allowed to play, and still have a problem with one of those. I'm going to move ahead to talk about the two things. Before we talk about the identifiable problems and how to identify them, I wanted to take this time to talk about the two conditions that happen in sports that can happen to a person who had every normal screening test. And these are because they are acquired conditions. And the most important one of those is myocarditis. That is, it shows up on the list here as the 6% of sudden cardiac death in young athletes. Myocarditis is an inflammation of the heart muscle that usually happens after a virus, and usually after recovery from the virus. This is why we'll often tell people, if you're an athlete, if you've had a viral illness, a summertime viral illness will usually be fever, diarrhea, vomiting, and in the winter it would be more like an upper respiratory infection with fever. Athletes who have overcome those symptoms, they're not having diarrhea anymore, their respiratory symptoms have gotten better, but they have any other complaints, whether it's chest pain, shortness of breath, palpitations, feeling their heart beating funny, or whether they just are still too fatigued to play, this is probably not the time to go right back into full-time activity. And if a person is having those symptoms, an electrocardiogram or an echocardiogram is worthwhile. Again, the signs and symptoms would be chest pain or pressure type pain. Often there'll be just chest discomfort, but also palpitations. And if a person has myocarditis, if they're identified, we treat it, usually just with nonsteroidals, sometimes with steroids and other medications. And many people will recover and go back to playing. But there is a 3 to 6 month rest period after that. So myocarditis, again, if a person has been screened and allowed to play, we just would like people to be aware of that because anybody can have myocarditis. The other one that I like to mention is commotio cordis, which is what happened to Damar Hamlin, which was very unusual because it's not as common in adults as it is in children, particularly in the 12 to 14 age range. This is a sudden impact to the chest that, if it happens at exactly the right millisecond in the cardiac cycle, can trigger an arrhythmia that just causes the heart to stop beating. There's no way to screen for this because it can happen to anyone. Damar Hamlin went back to playing in the National Football League, and somebody said, well, could it happen to him again? It could happen to him with the same frequency as it happened the first time. And when this happens, immediate attention with an AED and CPR is the most important thing. The one way to prevent this, I will say, in the United States, most cases of commotio cordis happen in baseball. They'll happen to a pitcher taking a line drive to the chest, perhaps a batter being hit in the chest. A little bit less so for catchers because they are protected. The way to prevent that is with a reduced impact baseball, and that's actually been shown to use to decrease the risk of commotio cordis. Although most organizations, including Little League Baseball Incorporated, do not use the reduced impact baseball. Talking about now, so those are the things that can happen to anybody. The rest of the talk after this slide is going to be talking about screening the completely healthy person. But we wanted to talk about the 7 warning signs that a person could look out for, or at least the things that cause concern for people, whether they're related to sudden cardiac problems or cardiac disease at all. And the one that usually comes up the most is listed second on this slide, and that's chest pain. We see it as pediatric cardiologists. We see a lot of children and adolescents for chest pain, and it's almost always not related to the heart. If a person complains of fleeting chest pain that happens spontaneously, it can happen several times a day. That's usually it's usually a sharp pain that's in one location. That's usually something that's called Texedor's twinge. It's just a random firing of a nerve fiber and not anything to be worried about. A lot of times having the cardiac workup and showing that the coronary arteries are normal and the EKG is normal actually makes that symptom go away because there's a subconscious component to it. But the chest pain that we would worry about is the same as it would be in a person in the later decades. And that would be if a person has chest pain that's provoked by a certain amount of activity. So if somebody says, I get chest pain every time I run for 10 minutes, particularly if that pain is over the heart. One of the things I've always thought is interesting in all cultures, if somebody's having chest pain from a cardiac problem, if you ask them where their pain is, they'll make a fist, they'll put it over their lower left part of their chest, and they usually lean forward. I say all the time, if I ask where their chest pain is, as soon as I see their fingers, I know it's not the heart, because wherever it is that lands on their chest, it's either muscle or bone pain, or it's that Texedor's twinge. But chest pain during activity, if it happens repeatedly, is something that should be checked out. Fainting is a not uncommon complaint in young people, adolescents and young adults. And usually that's vasovagal fainting. That's all just an imperfection of the autonomic nervous system. That usually happens when a person has been standing and there's a prodrome of feeling lightheaded, usually feeling cold and clammy, and then passing out and recovering completely. The fainting, and that we treat with drinking more fluid, taking more electrolytes, and being aware of the situation. But what we worry about is fainting that happens during exertion or immediately after exertion. So if we see somebody, if you can Google Hank Gathers and actually see his event, it looks different than the person who's standing in church or standing in the cafeteria line gets dizzy and faints. So if a person faints during their sport or immediately after stopping, that's a person that should have a cardiac workup today or tomorrow and should hold off on playing until then. Shortness of breath and fatigue are usually not a sign of cardiac disease in children and adolescents and young people, but where I would be cognizant of it is if a person is unable to tolerate for either of those complaints activities that they previously have been able to. The athlete who could run 5 miles and now can't run a half a block because of fatigue or shortness of breath should get checked out. And if it's shortness of breath, they should probably get checked out by a pulmonologist and a cardiologist as well. Family history is really important, and it's an important thing for everybody to know, and it's an important thing for screening people for cardiac participation. Again, heart attacks before the age of 50 or unexplained deaths. And when we really get into the situation, it's the person who's died suddenly, and a person sometimes in families will ask about whether there was an unexplained car accident in a person who was a good driver, an unexplained drowning in a person who was a good swimmer. Those may be signs of arrhythmias that were causes of sudden cardiac death. And also, if a person has a family history of hypertrophic cardiomyopathy or of aortic aneurysms like Flo Hyman, those are important to get checked out because all of those situations are what we call autosomal dominant genetic conditions, meaning if a person has it, there's a 50-50 chance that each of their first degree relatives has it as well. That's brothers, sisters, parents, and children. So if we have a family member, a parent who's been diagnosed with one of those things, then it's good for the children to be checked out. Palpitations are another warning sign. People will feel their heart racing when they're anxious. Athletes will appropriately feel their heart rate increase when they're participating. Nowadays, that people are wearing Apple Watches and Fitbits. One of the things I always tell people to reassure them is that if we were going to do an exercise test on somebody, we would shoot for a heart rate that's 220 minus their age. I will see people sometimes because they're a teenager running on the treadmill and their Apple Watch tells them their heart rate is 190, and that's if they're feeling well, that's okay. But if a person feels their heart racing and that spontaneously, and that causes them to feel lightheaded, to faint, that's a warning sign. Or the person who is exercising and they feel their heart either racing very fast or actually feel the sensation of their heart pausing, particularly if that leads to lightheadedness or fainting. Those are the people that should be seen right away. The rest of the time, for the next 10, 15 minutes or so, we're going to talk about pre-participation screening and what it is that we do in this country, what is done in other countries, and where I think we're headed. And probably for the first time, I'm actually really optimistic about the direction that the United States may be going in terms of screening, catching up with the rest of the world. But what do we do? If a person is going to play an organized sport that they need to be cleared for, the current recommendations of the American Heart Association and American Academy of Pediatrics include a fairly comprehensive history and physical that includes the family history and includes all the questions for those symptoms that I just talked about. And we don't do really any other screening, but this is a way of identifying people who might be at risk for one of these events to happen. In a lot of the world, we'll talk about that. The big question is the validity of adding an electrocardiogram to that screening. What are the benefits of cardiac screening? it's fairly obvious. If we can identify those cardiac conditions that we mentioned on that pie chart beforehand, then we can either steer people away from the activities that are going to cause an event, or we can manage those things to lower the risk of having those events, and we can monitor them much closely for those risks. So early detection is important. And if we did the series of really 3 tests, which we are not close to in this country, but electrocardiogram, echocardiogram, and either stress testing or event recording, you would be able to identify about 94% of the people who are at risk to have these things. And we would be able to, again, not just take them out of activities, but to allow safe participation. And the other thing is, which I mentioned before, once we find one of these conditions in a family member, that there's a cascade effect. We may be able to find it and not just protect that young athlete, but protect half of their siblings and maybe one of their parents as well from something bad happening to them. Screening can involve the medical history, the physical exam. Physical exam includes not only the presence or absence of heart murmurs, that might be indicative of some of the problems, although not that many, but the blood pressure. Blood pressure is a really important aspect of this. If a person has on their pediatric visit or their well child care or young adults when they're seeing an adult provider, if a person has high blood pressure, that is not, it's a reason to have a workup in a pediatric patient, but that's not an indication to take them out of their sport. If anything, it's an indication to keep them in their sport, because the first treatment for high blood pressure is always diet and exercise. I'll have this a couple times a year where a high school athlete has been taken off the basketball team because they have high blood pressure, and I will say they should be put on the basketball team. And then the additional testing, EKG, echocardiograms, we'll talk about those in a second. What are those tests? Electrocardiogram, EKG, that's just for people that are, that are the non-medical people in here. This is what you get if you're an adult when you go to the doctor. It's we're measuring the electrical activity coming off of your body, almost all of which is coming off of your heart. That's the line drawing on pink paper. And this is going to identify a lot of problems, even those arrhythmia problems, even when the arrhythmia is not happening in the 15 seconds that the EKG is happening. So there's a lot of information on the EKG, and probably by EKG screening, we would take that 2,000 athletes a year and bring it down to conservatively maybe 600 a year, just by doing EKG screening. An echocardiogram is an ultrasound of the heart. That's a more specialized test that is not going to be ubiquitous in our society anytime certainly in my lifetime. Takes about 45 minutes, especially a pediatric echocardiogram, because the difference between a pediatric echocardiogram and an adult echocardiogram is we're going to look for those congenital coronary artery abnormalities. And it takes a while sometimes to see the coronary arteries, but that's oftentimes the most life-saving part of a pediatric echocardiogram, if there is one. Stress tests are to find problems during exercise. And in the pediatric age group, in adults, we're looking for ST segments and TUA changes, signs that a person's having a heart attack. But usually, if a person's going to have a problem with activity in the pediatric age group, that problem will be in the form of an arrhythmia. And that's why in pediatric practice and in pediatric cardiac practice, we can often get the same information by having a child or an adolescent or a young adult wear a cardiac monitor. Our cardiac monitors that we have right now just taped to the chest. They don't get in the way of any activity. When somebody's wearing them, we encourage them to do all their activities. They can shower in them, and we can get not just 15 minutes on the treadmill, but we can actually look at the rhythm throughout life. And those are the ambulatory rhythm monitors. What do these things pick up? Again, an electrocardiogram is a lot easier to get and a lot more ubiquitous as a screening tool around the world. And that's going to pick up a large number of these diagnoses, the hypertrophic cardiomyopathy that I talked about, long QT syndrome, Wolff-Parkinson-White syndrome, and Brugada syndrome, which are electrical abnormalities of the conducting system of the heart that can provoke these things. An echocardiogram also will pick up hypertrophic cardiomyopathy, but most importantly, aortic aneurysms and the coronary artery anomalies, which will not show up on EKGs and do have a sizable portion of that pie chart. And then catecholamine sensitive ventricular tachycardia, it would be picked up on either a stress test or a Holter. And again, the two conditions we talked about before are not screenable, myocarditis and commotio cordis. Before getting into briefly the screening strategies that the rest of the world has and that the United States might be adopting, what happens, the most important part is what happens when a person is found to have these diagnoses. I've mentioned it a couple times that we're managing them, we're not taking them out of activities. This has really been an evolution that I've enjoyed watching through my own career. I remember 25, 30 years ago, even up to 10 years ago, having to take adolescents out of their sport because they achieved a diagnosis that didn't fit with safe participation based on American Heart Association guidelines, which were at the time a little more draconian and a lot more kind of regimented. If you're the best example is an aortic aneurysm. If you had an aorta that was just to the lower end of the upper limit of normal, you were allowed to play, and you could measure it 6 months later and be a couple millimeters bigger and fall on the other side of 2 standard deviations and be taken out. The guidelines have really changed, and the 2025 guidelines of the American Heart Association have entirely flipped to what we call the shared decision making, which is for the physician, the athlete, their parents if they're an adolescent, but not only that, the school, the athletic program, the university, to decide for that person what the incremental risk of their condition is and how much their participation benefits them. So athletes are not going to be taken out just because a diagnosis appears on their medical form anymore. Again, we're responsible people. If I see somebody with severe hypertrophic cardiomyopathy that is causing risk, I'm not going to let them play college lacrosse. But I do have patients with the diagnosis of hypertrophic cardiomyopathy who are playing sports at the collegiate level because their risk is extraordinarily low, and we believe that the support around them is adequate to give them the opportunity to continue playing. So that's an important thing, that people should not be afraid of screening, because it's not like a healthy person is going to be taken out of their sport lightly. What are the screening and what's the history and the current status of screening around the world? Well, Italy started this, believe it or not, in 1982. Since 1982, if you're playing a competitive sport in Italy, you have to have an EKG. They did this in response to an unexplained, almost epidemic of sudden cardiac death that happened over a 3-year period and that triggered some type of screening. And that's why the results of it are probably a little exaggerated. It's been said that 90% of cases of sudden cardiac death in Italy are now prevented by screening, and that may be because we're comparing to a slightly inflated number to begin with. But they've been doing it for over 25 years. Now in Italy, if you're playing a competitive sport, and I'll talk about what that means in a minute, you not only get, from starting at the age of 12, you get an EKG, an echocardiogram, and a stress test, and those tests get repeated annually or every other year as long as you're playing. How could they possibly do that? It depends on how you define the athlete. Notice they screen 100,000 athletes a year. In the United States, if we were screening just our high school varsity athletes, that would be a drop in the bucket. Those are athletes that are participating at a level to basically get them involved at the federation level. And that's why it works. Screening works in other countries different than the United States. Just going to the other countries before I get to that. Israel started screening in 1997. They have not shown the tremendous decrease in sudden cardiac death, mainly because it's sensed that they were unofficially screening before that, but that was like the mandatory screening for athletes. FIFA and the International Olympic Committee recommend EKGs for anybody participating in anything that kind of carries their banner starting at 12 years of age. And because a lot of that has to do with the European countries, the European Society of Cardiology has recommended EKG screening as well, and across Europe there are a lot more countries that are screening than not screening. These are kind of the major organizations that might comment on athletes. The International Cycling Group actually has the most extensive screening, because they not only require an echocardiogram, they require it annually during the second decade of life and beyond. And they also require stress tests. But here we are in the United States, not even recommending EKGs at the high school or the college level. I'm going to skip that. And this is just because I mentioned it before. These are basically the list of countries that are screening. I have to point out Japan, because Japan is the country we keep talking about screening our athletes. And one reluctance we would have in this country would be cutting it off at athletes. Japan actually screens all school children with EKGs, and they do it the most sensible way by putting EKG machines in the schools and having the school nurses do them. So apparently by the time you graduate from high school in Japan, you've had 3 EKGs. And these are the countries that are not doing mandatory screening, headed by the United States. We'll talk about Florida in a minute. I throw this up not for anybody to be taking this, but I mentioned the European Society of Cardiology, and they have a set of guidelines that have been duplicated and amended a little bit in this country in something that we call the Seattle criteria. Group of experts in sudden cardiac death got together in Seattle about 15 years ago and said, hey, we got to get ahead of EKG screening, so that when we do EKG screening of young athletes in the United States, we will make sure that the EKG machine doesn't send too many people for too many tests. This is very important, because if you've ever seen an EKG, this is not an AI thing. EKG machines offer an automated reading, and they've been doing that for 35 years. A completely normal study would say normal sinus rhythm, normal EKG. But especially in pediatrics, the EKG machine 75% of the time says something other than that. And most of those things are benign. So the ESC and the Seattle group put together this handy formula that I use on a daily basis. I am actually grateful that in New York, we have a couple of pediatric practices who have been doing EKG screening and doing it appropriately. Carnegie Hill Pediatrics, I think, has been doing it for about 10 years. We have some folks on from Atria. They do routine screening EKGs of their teenagers, and we proofread them against these guidelines. If I would, and I would say about 90% of the EKGs that say something other than normal sinus rhythm, normal EKG, get cleared by me as not needing a cardiac workup. So by doing EKG screening, we're not adding, we have to be careful of the cost, that we're not adding the cost of an EKG, which is small, and then all the other testing. So having these guidelines is an important first step. And what's the cost effectiveness? Well, it's hard to put a price on a human life, but we do have that. We basically look at a screening test and say, what's the cost of it? And if you can calculate how many quality years of life have been saved divided by the cost, that number is less than 50,000. So if it costs less than $50,000 per year of life saved, a test is we do lots of tests is cost effective. We do lots of testing that is either not been subjected to that analysis or doesn't meet that analysis. But most modern attempts to look at EKG cost effectiveness in the United States have shown it to be cost effective. And the most important one is that Stanford did a study a couple of years ago using data from the Pac-12, where the member universities either did or they mandated a cardiac clearance, but they either did or did not mandate an EKG. So the cost was not zero. The cost was seeing the doctor and being cleared, or seeing the doctor being cleared and having an EKG. And the screening with EKG was in terms of year of life saved, half as expensive as actually seeing a doctor and not having the EKG. So EKG screening is good, and cost effective by the definition that we have. What do we do with that beyond screening and finding people? How do we keep our athletes safe? Well, it's important to have emergency preparedness. This is why it's important for schools, athletic programs, any public place where people are going to participate, to have individuals there that can identify a sudden cardiac arrest, that can do CPR, that we have AEDs present in the schools. The school can't have one if they've got 5 different teams that might be playing at 5 different places. And the availability of these personnel, and that means people in the community were ready to do this, and the equipment has been life-saving as well. And that leads me to really kind of the last factual point, where it sounds a little bit counterintuitive and a little bit like the United States is behind on the EKG screening. But I'm really excited at the fact that for the first time, Florida, starting next fall, will be mandating screening EKGs on all of their high school athletes. It's still a work in progress because we're not entirely sure what they have until fall of 27 to decide what to do with those EKGs. But this is by something called the Second Chance Act. It was enacted in the Florida legislature, takes effect this August. It's the first time in the United States that we're doing that. This was spearheaded not by some new medical information, but by families of children and adolescents who were lost to sudden cardiac death, telling their story and advocating for this. And what I keep saying, there's a couple different ways that this could go. This could just stay a Florida event and be a failure in 10 years. It's not going to go from Florida to be a national thing because the federal government doesn't take this jurisdiction. This will have to be done at the state level. I was assuming that it's going to grow out from Florida, from the contiguous states. If Florida does it, Georgia, Alabama are going to have to do it because their populations will be aware of it. But it very well may be that the second state to do this will be New York. There's a family in Long Island forming an organization in honor of their 17-year-old who passed away during a hockey tournament. And this is the kind of recognition that gets these things started. So when you hear about it, I do think universal EKG is coming our way in New York. And I think that we're probably going to be further up the chain than a lot of places. So in summary, these things, when you hear about them, either in social media or in the news, they are tragedies. They are a needle in a haystack. They are relatively rare, but we hear about all of them. But they almost always have an explanation. They are not being hit by lightning. Commotio cordis, myocarditis, but the other things were things that could have been identified. So the causes can be identified and they can be managed. EKG screening will find a lot of these and is cost effective and can identify most at-risk athletes. And the most important thing to remember is the diagnosis of these things does not mean disqualification from sports. So what can parents be doing? They can be advocating for EKG screening, important thing for families to know your family history, know what it was that happened to that uncle of yours that they talk about who died when he was 19. Watch for the warning signs. Again, don't be so afraid of the chest pain, the palpitations, the fainting that is common, but know those scenarios that I mentioned that might point to cardiac disease. Learn CPR and the use of the AED and make sure that your schools have that and have those personnel available. If the opportunity comes to support legislation for cardiac screening, remember, part of the problem in the United States is that we have put our sports in the jurisdiction of our schools, which other countries don't. Other countries can mandate this to the sports federations because if your job in life is to find the next Lionel Messi, the cost of an EKG isn't going to get in the way. That's why Italy screens 100,000 people a year and not 10 million people a year. But the time is probably coming. And then also consider elective screening if your child is going to be very, very physically active. With that, I'm going to pause for any questions. If anybody has any questions, feel free to chime in or to put them into the chat.
Quick question.
Sure.
I'm just reviewing the norm. Thank you for that page that says pediatric normal EKG findings and abnormal and possible. I think I have that somewhere, but this is great to lay it out like that. I'm just writing down the abnormal ones. It says T wave inversion for number one, but up in the normal, it says there's a couple ways like T wave inversion V1 through V3 less than 16 is fine. So what type of T wave inversion is abnormal?
It's a great question, and this is the one that comes up the most. You know, the T waves, the way an EKG works is there's the six leads that come from the arms and legs, and then the six that come across the chest. In the normal EKG, uh, from the time you're about 4 days old till adolescence, the T wave, which is the little camel hump that's after the QRS spike, in the right side of the chest, curiously, will be down going. And it has to be during childhood. If a person has a T wave that's upright and they're 5 years old, it means that the right side of their heart is too thick. But by the time you reach adulthood, to make it easier for the adult cardiologists who read so many EKGs, the EKG points upright in all of the chest leads. So what we call an adolescent T wave progression is T waves that are downgoing in the right side of the chest and upgoing by the left side of the chest. That's normal even to adulthood. If a 25-year-old had that EKG and they were a healthy person and never had chest pain, that's, by the way, what my EKG looks like. I have an adolescent T wave progression at 65 years of age. But it's important, and that's why it seems contradictory, but it's not. And one of the things that the Seattle criteria had to acknowledge versus the European group was that, and also some of the voltage for thickness, because EKGs of African American adolescents can sometimes be a little bit different than of Caucasian adolescent athletes, and because it's about the only difference between the Seattle and the ESC is acknowledgement of that, because we don't want, again, to apply criteria that would result in too many referrals. It's a great question and a great observation.
So should that say T wave inversion greater than 16 for abnormal?
Yeah, well, it depends on where what lead we're talking about, and also the ST segments will allow. There's another part where the ST, which is between the QRS and the T, in adolescence is allowed to follow the T wave. The same EKG in a healthy 16-year-old versus a 45-year-old who's coming in complaining of chest pain could signify a heart attack in that person, but just a healthy adolescent EKG in the
Okay,
adolescent.
thank you. Thank you.
I have a question.
Hi,
Can you
Gina.
hi, can you comment on the possibility of false negative EKGs and what percentage that would be?
Well, that's a great question because I think it depends on how you define false negative because an EKG, a normal EKG would be what I would expect in a child with a congenital coronary artery abnormality. So that's one where if a person had an EKG that was normal, had a condition that wasn't screenable by EKG, and then had a sudden cardiac arrest, I wouldn't blame the EKG. I would just say that it's because there are diagnoses that aren't picked up on EKGs. So most people, some of those things can be variable, but once a person has enough hypertrophy, say, for hypertrophic cardiomyopathy, one thing that I would also point out is that I think some of the strongest advocates for EKG screening in the United States would say that the proper way to do it would be to do it twice, once around age 12 and once around age 18. And that's because hypertrophic cardiomyopathy being the biggest group, sometimes a person has the genetics for hypertrophic cardiomyopathy, but it doesn't manifest itself until puberty. So you can have a normal EKG at 12, and then at the end of puberty, have an EKG that shows hypertrophic cardiomyopathy. And the echo can be the same way. That's the reason that those federations, like the Cycling Federation and FIFA, and in Italy, because a lot of it is about cycling, that's the only reason for them to advocate repeating the EKG every year.
Thank you.
That's a great question. Are there any others?
Dr. Finn, maybe you can look at the chat. I think there is a few questions.
Yeah, let me see.
Yeah, thank you.
Oh, here we go. I'm sorry, I had clicked off the thing. Yeah, that's a great. Greg had suggested showing the EKGs from the conditions, and I didn't do that because we were going to have a lot of a lay public on here, but I can do that the next time. Energy drinks, Red Bull. Oh, that is a great question. I'm so glad that came up. Energy drinks, one of the greatest factors for palpitations, fainting, all of those things in our healthy people, not sudden cardiac death, are caffeinated beverages. I tell people all the time that come to me with lightheadedness or fainting or anything like that. If it seems like you drank a 24-ounce Starbucks drink and 45 minutes you went and peed 35 ounces, it's because that's probably true. The energy drinks, so not only that the caffeine in terms of stimulating the heart can not only be dangerous to provoke problems in the people who have those problems, but the energy drinks with a lot of caffeine in them will dehydrate your athletes. So I feel like it's really important for people to be hydrating with fluid whenever they're participating, that they're hydrating with fluid that has electrolytes in it. And there are a lot better choices and a lot more choices than Gatorade, which is still kind of the gold standard. But a lot of the electrolyte supplements that we can put in water are better holding that water in for athletes and for everybody else. But the combination of dehydration and the constant stimulation of the caffeine is bad for everybody. But in terms of provoking problems for people with catecholamine sensitive ventricular tachycardia or hypertrophic cardiomyopathy, long QT syndrome, the caffeinated beverages are terrible for that. Bayless was asking about heart. I didn't mention heart murmurs because it's very much heart murmurs are there, but it's a great chance to point out heart murmurs are very, very common. And in a healthy person who's 16 years old and playing a sport, if a person was born with a structural heart problem, especially in this country, it probably would be picked up. The serious ones we're picking up prenatally or in the nursery. we're picking up the other ones. If you bring me 105-year-olds, I'll hear a heart murmur on 70 of them because it's my only skill. I don't ask your pediatrician to be picking up all of those, but don't ask me to look in the ears and see if a light is bouncing off of the eardrum. And most of those are very, very common, innocent noises. So I don't. That's why I don't add it to the risk factors for athletes, because we don't want parents to freak out if they've been told that somebody's hearing a noise coming out of the heart. And there's another question. Thank you, Neil. Using these chest protector or chest shield for baseball pitchers. There, there's that kind of tight mesh protector that hasn't been shown to be effective very much. Anything in baseball, I think the best way to in that sensitive age group to avoid commotio cordis would be to use the reduced impact baseball. The science behind commotio cordis was worked out by Barry Marin. It's incredibly well done, and showing more that the reduced impact baseball had more of an effect than anything other than a hard covering. Now, one of the things I will say, my younger son is a college goalie at Wilmington University, and again, I know, and I'm a sports parent, I'm a parent of an athlete. If anything had ever just come up on a routine test that made him give up lacrosse, it's really the most important thing in his life, and it's where he gets his self-esteem, and I'm grateful for it all the time. But we talk about advocacy groups within a sport. U.S. Lacrosse, about 10 years ago, actually designed a chest protector for goalies to use. And there's only 3 manufacturers, and in any U.S. lacrosse event, which is any lacrosse event, the goalie must wear one of those. And my son, at least 3 or 4 times a year, even at the college level, will have to pull up this jersey and show the referee that he's wearing that U.S. lacrosse. Because obviously those are the without a chest protector, commotio cordis and lacrosse would happen too much. But kind of the short answer is it's a hard nut to crack in baseball, because a pitcher isn't going to wear a chest protector like a catcher would, and nobody's really shown that fabric one actually does anything. Oh, we've come up on the hour exactly. If anybody has any other questions, feel free. Certainly take the information for parents if anybody scans the QR code. I'm just going to go back again I apologize for some of the typesetting happened. We had to switch modalities a little bit over some technical thing, but that's the phone number in my office, my email, and my website, where I'm back to blogging again. We just posted a blog this week about cardiac screening with a lot of this information. And I do think that we're going to look back a few years from now at 2026 and remember it as a turning point in this country, I think, for the safety of our young athletes. So I want to thank everybody for coming. I want to thank Melis and Doctoloop for providing these, keep an eye out for webinars like this across the platform, because I think this is going to be a way to communicate very well with patients, families, and the community, as well as our medical providers who are interested. So thank you all for coming.
Thank you.
Thank you.
Thank you.
Thanks, everybody.
Hey, Pat, it was great. I'll set up a call with you soon.